Good morning, one and all. We would like to welcome you on behalf of the Scientific Committee of All India Ophthalmological Society. This year, we have begun a new initiative, which is the Subspecialty Days. The whole concept of Subspecialty Day stemmed from similar ones that you see in the American Academy, where you want the best of the people under one roof in one session to give you pearls about A to Z of that subspecialty. In this hall, today we are going to have the subspecialty day in the specialty of refractive surgery. And we are going to begin this day with the first session, which is finding the right candidate. To join me as a chairperson of this session, I would like to invite Dr. Rajesh Fogla to please come and come on the dais, please. Okay, whatever. So I think without further ado, we would like to now start the session. And I would like to invite one of the pioneers of refractive surgery in the country, Dr. K.P. Reddy, sir, who is the medical director of the Maxivision Eye Hospitals. He has been at the forefront of refractive surgery for more than 3 decades. And he's somebody who has seen the whole journey of the refractive surgery and somebody who is always at the cutting, bleeding edge of the technology. So, sir is going to take us through over the overview of refractive surgery options as of today in 2024. Over to you, sir.
Good morning. Good morning. Vardhaman, thank you for having me. I'm here exclusively for you. I have to leave again this afternoon, 12 o'clock, back to Hyderabad. It was a big effort to be here, but I'm so happy to be here after almost 6 years. So I've had many things, like you said, since 74. I've been so many things, and I was fortunate to have the femtolaser, research in cataract surgery also. So without wasting your time, I just want to share with you. I started with PRK in the year 1991 in England. So I'll just share with you what I was doing in England. Started with PRK. Then for astigmatism, I tried the PRK with erodible mask. Then for hyperopia, then LASIK, then I used a holmium laser, which is attached to the Summit machine, what we call laser thermokeratoplasty, and had mixed results. Then I moved in 96 to India. Again, PRK, started LASIK. I used to do a technique for hyperopia, which is purely surgical and not laser, called MLK, microlamellar keratoplasty. So I just wanted to share the past because where are we today in 24 and what's it going to be? So then after MLK, I realized high powers I couldn't treat. I went to Groningen and introduced Artisan PIOL. Then Cyoptics, then femtolasic came and saved a lot of us with a lot of issues of the flap. Then came trans-PRK, and then I requested AIOC to do the same PIOL, but then came ICL. Then I did some research, prototype research work for intracar and supracar for Bausch and Lomb. And in 2010, I moved into flax, and then after doing that, I just introduced a word called phaco mix and then smile lastly. So basically what I'm trying to say is, rather than being theoretical, I thought I'll just give you my personal experience since then and today. What stood the test of times from the beginning till today? That is PRK. PRK, whether you call it trans-PRK or PRK, whatever manual, but PRK from that day till today, we just can't live without it. So it's one of the greatest refractive surgical procedures. Then came LASIK for hyperopia, and then for higher powers, the ICL, and today's, the SMILE. I put phaco mix here. This is a term that I use in my clinic for my patients, but in reality, it is nothing but a clear lens extraction with multifocal or EDOF lenses, and ultimately delivering the promise that you make, making the patient see without glasses. So 2010 is when I first went to Aspen, Colorado to present my first study of femtolaser. Why I'm sharing this is because, you guys are all one of the greatest refractive surgeons of this country, and then there's nothing that I can tell you, but I can only share with you my good, bad, and ugly side of refractive surgery that I had to go through. So these phaco techniques, or what it is today, anybody over 19, a boy or a girl, we can remove glasses. Whether it is presbyopia, whether it is, cataract surgery. You all know that cataract surgery today is refractive surgery. So what I do is I do a flax outside the OR and then a mix inside, and then I use the WaveTech Aura biometry on the table and put a premium eye oil. And if any residual power is left, I make a great effort to treat that as well with PRK. All this is happening because patients' expectations are becoming higher and higher. And our LASIK, the refractive laser surgery that we're advertising a lot all over the country, is putting pressure on us for the older group to be without glasses like myself. Even in 2010, while I was experimenting, I requested Dr. Steve Slade in Houston to do for me, and I am now without glasses. I can see everything and play golf and do all kinds of things. And then ophthalmologists generally, because I did other specialties like general surgery, orthopedics, accident emergency, neurosurgery, and aviation medicine, then I came to ophthalmology. But what I realized is in ophthalmology is a different breed altogether. They want perfection. And that is the reason. But then basics have not changed. The basics have remained to be the same. Still, the cornea, is the most important thing, and we still have to respect that you cannot operate, whatever laser technique that you use on a lesser cornea. That I don't need to, you all know that. So today in 2024, yes, I am practicing, PRK. LASIK is literally gone from my hands. I'm only using SMILE now because personally in England, I have had a couple of medical legal problems related to LASIK in those days because it was a manual microkeratome in 95, and it created some striae, folds, and then epithelial ingrowths, and then I got into trouble. So I'm sure there are many ophthalmologists all over the universe who will agree that flap is bad news. So I'm thankful to Rupal Shah here that, I went to her house, stayed in her house, got to know SMILE, and then started SMILE, and I'm so happy that I don't raise a flap today. But occasionally there are, situations where you have to use a LASIK. So then you make a lot of effort to make your patient happy because sometimes you may not be accurate, even when you do a clear lens extraction in a presbyope. So, and I never change IOLs. And lastly, all I can share with you is that counseling is the king. What you promise. I tell all my patients prior to the operation what to expect. And I never promise, like any one of you, 100% result, but also color changes, what halos, everything I explain, and only when they agree, I do it. So year 2024, all you guys are going to do great refractive surgery, and There are so many techniques that have come since 91 that I started, but there are certain procedures which have stayed. Thank you.
Thank you so much, sir, for a great overview and also for taking us through your journey, which is amazing, very inspiring, of course. So I have two questions for you.
Thanks, Vandaman.
Thank you, sir. And sir, currently, out of, let's say, 100 odd patients that you do,
Currently?
if you do 100 refractive surgeries, out of that, so can you just tell us ballpark figure about what is your percentage of what kind of refractive surgery today? Like how many percentage is now SMILE versus PRK versus ICL?
Today, as I'm doing right now, almost 70 to 80% it is SMILE. Okay, and then PRK. It's between PRK, SMILE, and then ICL or IPCL from AIOC. But that's where I stand. I'm literally living on this. I'm so much involved in these three particular techniques in refractive surgery, and I use a lot of flax for presbyopes.
Right.
These are the four techniques that I practice. This is my bread and butter today.
Yes. Sir, for a patient who is -6 diopters myopia, having a perfectly normal cornea, what will be your choice of the procedure?
-6 cornea, I would still consider a laser refractive surgery, SMILE in my case. Yeah.
Sure.
And if it is a lower power, I mean, I have treated a SMILE procedure up to -0.75.
Right.
Okay?
Yes.
Because the reason being is people come from all over the world and then they want a quick recovery. That's when I did that for sporting purposes as well. But otherwise, SMILE.
Yeah, you can
Thank you so much,
increase
sir.
the lenticule thickness, so even a 0.75 can be well managed.
Sorry, Chitra, sorry.
Yeah.
No, even the lenticule thickness can be increased, so you can very well manage a -0.75 also
Yes,
with SMILE.
yeah.
Thank you so much, sir,
Thank you.
for coming all the way for this. It really
Thank
means
you.
a lot to us.
I just came for you, Vardhaman. I'm leaving in the afternoon at 12 o'clock.
Thank you, sir.
This
It
is
means-
after 5 years. I should congratulate you. Thank you.
Thank you.
Thank you, sir. It is a big honor for us at AIOS, and thank you so much. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you. Yeah. So we will go to the next talk now, which is, of course, naturally how to select your patients. One of the most important tools that you have in your hand are the topographies and tomographies. And to take through the pearls of the same, we have Dr. Rajesh Fogla from Hyderabad, who is the medical director of the ophthalmology department at the Apollo Eye Clinics, eye hospitals in Hyderabad, has been one of the pioneers of both cornea refractive surgery in our country and great teacher. Over to you, Dr. Fogla.
I think we should connect our laptops beforehand itself, the other podium, and Dr. Pooja, we would want you to be the next speaker there.
Good morning, everybody. I would like to thank Vardhaman for including me in this program. I'll be just giving you an overview on corneal topography and tomography. I have no financial interest to disclose. As we heard from Dr. K.P. Reddy, millions of people undergo refractive surgery for correction of myopia, astigmatism, and hyperopia. And to achieve predictable outcome and minimizing the risk of complications, it's important that you need to have proper assessment of the corneal shape and thickness, and you use advanced diagnostic tools for the same. Topography refers to a two-dimensional mapping technique where you look at the anterior corneal surface, and it is very useful for detecting astigmatism and early keratoconus, and these measurements can be affected by the tear film irregularity. In contrast, the tomography refers to a three-dimensional imaging technique where you get information about not only the anterior curvature, but the posterior curvature and the corneal thickness across the cornea. Now, the common devices that you have in clinical practice for topography, even in my practice, I started off with the TMS-1 and then gone up to TMS-4. You have the Atlas from Zeiss, the Topolyzer from Alcon, and the Keratograph from Oculus. And among the tomography devices, the popular ones that you use in clinic are the Sirius from CSO Italy, the Pentacam, which everybody uses worldwide, the Galilei from Zimmer, and also the ObsCan from Bausch & Lomb. The three main principles of performing corneal imaging: in the topography, you basically use the Placidos disc reflection. This is used right from the early days. Here, the reflection of those concentric rings, whether they are symmetric or they are asymmetric, that helps us detect any changes in the corneal curvature. You have the scanning slit images, which takes the scans from the anterior and the posterior cornea, and using a triangulation method, it helps determine the power of the cornea. Or you can use the Scheimpflug photography, where a rotating Scheimpflug camera images thousands of points based on which the anterior and posterior surface can be reconstructed. The measurements are basically to help interpret. They are generated as color-coded maps. The warmer colors, the red color, indicate the steeper cornea, and the cooler colors like the blue, they depict the flatter curvature. You also have the elevation map in reference to a best fit sphere for both the anterior and posterior corneal surface. So these maps tells you, compared to that best fit sphere, whether the cornea curvature is elevated or depressed from that point. And also it provides corneal thickness map across the cornea. And these measurements are automated. You have advanced data analysis and software screening program, whereby you get a lot of indices that tells you, as compared to a normal cornea, how far this is deviated from the same. For the anterior corneal curvature map, this was a very early paper back in '96 Rabinowitz had given. So you have a lot of these common shapes of round, oval, symmetric or asymmetric bow tie, and skewed bow ties and irregular maps. Like this is from a TMS-4 map. You can see that it gives you only about the anterior curvature. You can look at it. This is a symmetric bow tie kind of picture. And it also has keratoconus screening software, where you have the keratoconus, the Kleist-Meda software or the Smollett Kleist, where basically it looks at the asymmetry between the superior and inferior half, center and surround. It looks at the surface regularity index, the steep K, whether it's beyond 48 diopters, and then it gives you in a percentage what is the likelihood of this being abnormal. Also, the common map that we use is the axial curvature map, but there is another map called the tangential or the instantaneous map. So the axial curvature maps are a little bit more smoother, because the differences in curvature are derived from a central axis, whereas the tangential curvature map don't take the central axis into consideration. It takes into account the local curvature. And if you look at, this is very useful when you look at the axial maps, is the first one, you look at the map, it looks like a nice central ablation, but it does not provide you significant information about what could be the optical zone. But if you go on the same onto a tangential or a curvature map, it tells you exact zone where between the treated and the untreated area, there is a sudden change in curvature, which is highlighted very well. And you can see that this is a very small optical zone. So if your patient has a mesopic pupil, which is larger than that, patient would be symptomatic. So it basically increases, it magnifies the curvature abnormalities on the surface, but sometimes if you're not familiar looking at the map, you can get confused. So it's important when you read a map that you look at which type of curvature map it's image, whether it is asagittal, axial, or it's an instantaneous or tangential map. Also pay attention to the color coding as well. You have something called the normalized or the absolute scale. A normalized scale is within a range of steep and flat K that's based on the map that's imaged. So it basically, the color coding can change in a normalized map. Whereas an absolute scale, the colors remain the same. It goes from a very low dioptric power of something like 15 or 20 and goes up to 100 in different steps. So there the color won't change. So ideally you should be looking at all your maps only in the absolute scale, and only when you want to highlight the changes a little bit more, or you want to magnify them, you can look at a normalized scale to see what kind of variation you have on the surface. Otherwise, what happens is, if different machines have different scales, if you don't take into account what color-coded scale you are looking at, just by looking at the color-coded map, you can get confused, especially if you're looking at keratoconus progression. In a different scale, it may look like early keratoconus. The same thing in a normalized scale may look as very advanced keratoconus with a lot of red color in the map. This is again, you look at the quantitative indices in terms of looking at the SIM-K values of K1, K2. You look at the central pachymetry. Sometimes in a refractive surgery, you may base your decision on doing a laser refractive surgery just by looking at the K readings and the corneal thickness. Let's say the K reading is between 44, 45, and your corneal thickness is 510 microns. You might think, oh, this patient is suitable for undergoing a laser refractive surgery. That's where the qualitative appearance of the map is also very important. So if you look at the axial or the sagittal map, you will see that there is a bow tie, but it's a lazy bow tie. That means the axes are skewing. So when you see that skewing, you know that it's abnormal. So besides quantitative, you also have to look at the qualitative map, what you're looking at. Newer tomography devices also have their own software where it shows you what is the probability of the eye, that topography being abnormal. People familiar with Pentacam will tell you that you have the bad D value. Again, there are 5 indices looking at the anterior curvature, posterior curvature, corneal thickness, deviation of the corneal thickness. So all these points you should be familiar with when you look at a map. Clinical application in refractive surgery is mainly for preoperative assessment to look at the shape, thickness, and stability. It also helps you decide what kind of treatment you're going to do. If you have a borderline thickness, maybe you'll go for a PRK, or if you have adequate thickness, or if you have an asymmetric bow tie, you may want to do a contour. So, and post-operatively, to assess the outcome, the enhancement if required, and any early detection of complications. Besides refractive surgery, it's useful in keratoconus, in contact lens planning, planning of intracorneal rings, and monitoring disease progression. The newer advances in tomography, topography is that you have, every now and then you have newer software coming out. You have faster acquisition time. These are automated, so it doesn't require too much of manual involvement. You have devices which are integrated with aberrometry. You can do biomechanical assessment. You can do optical biometry. You also have anterior segment OCT integrated with that. I think the subsequent speakers will talk about it. And artificial intelligence is also making it easier for better screening and predicting outcomes of the procedure that we do. So basically, if you do have one of these devices, the most important part is that read the manual, be familiar with all the indices, whatever the map tells you, unless you know the machine properly, you won't be able to derive all the benefit out of it. Periodic calibration is very much necessary, because if your machine is not calibrated, it can give you an erroneous result. What you should do is, in your clinic, if you have employees, you should, besides doing on a test target, you can keep repeating your tests on the employees that stay with you for a long period of time, so you exactly know if the measurements are varying. And you can always compare with additional devices to see that if you're getting a SIM-K reading in one, it should correlate with the reading in a different device. So if you have a proper functioning machine, your results will be more accurate. They are integral part of refractive surgery, plays a vital role in enhancing the precision and outcomes in refractive surgery. And integration with various other technologies in the future will make it much more easier for the refractive surgeons, and it will become a powerful diagnostic device. Thank you for your patient hearing.
Thank you very much, Dr. Rajesh. That was a very crisp talk. In the 8 minutes you tried to convey your best. If all of you could be seated, we could take the questions as once the talks get over. So we next go on to Dr. Pooja Kamar, who actually needs no introduction, belongs to the next generation, but is taking refractive surgery forward in our country and beyond in leaps and bounds. So she's going to be talking on collagen imaging and role in refractive surgery.
Thank you, ma'am. That was a very generous introduction. I think I have a lot more to do than you introduced me as. So, as ma'am said, what I'm going to be talking about is collagen imaging and its role in refractive surgery. It's a little bit futuristic, but yes, like how we've, as Rajesh was saying, how we've moved from a topography to a tomography and now biomechanics. I think this will be a very well integrated technology in future as well. So, ma'am is of course going to be speaking about biomechanics, but we do come across scenarios in our practice every day where topographies are absolutely normal, but your biomechanics or indices like CBI, TBI do not match with what your topography is trying to tell you. So we do get confused. However, we do our best, and out of all the options available, like KP sir said, we can choose whether to do a LASIK, SMILE, an extra procedure, or a trans PRK, or a phakic IOL. And based on all these parameters, we do have wonderful algorithms also, like when to choose which procedure for each of these patients. Then why is the need to understand the collagen? We do have already indices which tells us whether this is a healthy cornea, whether it's a suspect keratoconus, whether you should do a refractive surgery or not. However, in spite of all this, we do come across cases. These are two patients. First patient is absolutely normal. Second patient has a borderline biomechanics. However, the first patient who was absolutely normal landed up having an ectasia, but the second patient who had a borderline biomechanics is doing well. It's post-surgery around 8 years, a well-centered ablation, nothing has happened. So what is driving these ectasias? Why is this? What are these unknown factors? So we needed a solution to it. So there are enough studies which have happened on from various in vivo studies using probably cadaveric eyes or lenticules to understand the collagen structures. And what we have proven till now is that if your collagen density is lower to begin with, then even if your topographies or if your biomechanics are healthy, those patients are still at higher risk of developing ectasia. But at this point of time, only way to identify the collagen is to excise the tissue and do it, which is not practical in daily practice. So is there a way where we can have a non-invasive tool to study this collagen fibril orientation? And can we translate this knowledge into clinics for refractive surgery screening patients and choose the right procedure for them? So we have built this polarization sensitive OCT. It's nothing like but your like what you use SLO in your glaucoma practices. It's a similar principle where a polarized light is thrown on the patient's cornea, and all the structures of the cornea is going to take up this polarized light, but the stroma is going to bifringens it. So that's how we use this advantage, and we study the collagen of the patient. So why not other OCTs? Why not any existing commercialized OCTs? Because we need a higher depth of the bandwidth, the pupil detection, the image depth resolution has to be different, the pixel and all that. So that is much more superior in polarization sensitive OCT compared to other structures. And because of that, in addition to epithelial thickness on your stromal thickness, it also gives you the Bowman's thickness. You can actually quantify what is the Bowman's thickness in different layers. And you can also study the collagen orientation, like how dense the collagen is, whether it's normal or not. So why is Bowman's layer important? Because if you see this patchy Bowman's layer where it's thin in one area and whether it's thick in one area, this is a sign of a thin or an irregular Bowman's membrane, and this is going to be unable to maintain the integrity. So if you do any surgery on these patients are at higher risk of developing ectasia. However, if you see this thicker Bowman's, which is even all over, this is a very good Bowman's, and if whatever procedure you do on this patient is going to like have a good integrity post-surgery, so there are least chances of ectasia. That is one of the role. And the other thing what we get is, this is the collagen orientation what you get. So in simpler terms like a topography, darker the blue or violet you see means denser the collagen is in that area and it's well aligned. But if you see the lighter blues, that means it's on the weaker side. So this is what we see in a formfrous keratoconus case. If you can clearly see it's a formfrous keratoconus case, and there is a partial loss of orientation and arrangement of the collagen. And in a keratoconic case, there is a complete loss of orientation and arrangement of the collagen. You can see that the fibrils are not well aligned, and they are very haphazard, and you can see lots of green, yellow, and red. That means it's weaker. So how are we going to apply this knowledge to clinics? Of course, we'll have topography and biomechanics to help us. But if you have a collagen imaging, it will able to tell us how is your thickness of the Bowman's and how is your collagen orientation, whether it's normal, whether it's a patchy Bowman's with an abnormal collagen, and whether everything is abnormal. And based on that, you can choose. If everything is fine, you can choose a procedure of your preference. But if you have a thin Bowman's with a normal collagen level, you can choose a PRK or a SMILE extra procedure for lower dioptric error. Or if it's a higher diopter, you can choose a phakic IOL. If it's a thick Bowman's but an abnormal collagen orientation, you choose to do a trans PRK extra if it's a lower dioptric error, or a phakic IOL if it's on the higher side. And if everything is abnormal, you know that this is not a patient who deserves a corneal-based procedure, but you need to do a phakic IOL. So let's take these two case examples. First case, you can see a little bit of inferior steepening is there, and a little bit of posterior elevation. And the indices are on the abnormal range, whereas here absolutely everything is on the normal side. But if you go ahead and see, first patient has a healthy Bowman's, completely healthy Bowman's, and this patient has a thin Bowman's layer. And the patient who has apparently a healthy looking topography has a complete loss of orientation of collagen in this area, whereas this patient has a normal orientation of collagen. So once we have a good amount of data in which once this is commercialized, here I will probably go ahead and do a refractive surgery, probably a trans PRK, but here I will not do it because this is the patient who is likely at a risk of developing ectasias. So to conclude, yes, we are developing one of the first polarization sensitive OCT which can be used in clinics to study the collagen orientation and arrangement. And it can help us to differentiate suspicious corneas, which can be revealed with a unique distribution of collagen before their topographic manifestations has started. And it can become an integral part of refractive surgery screening in future to identify the warning signs in seemingly healthy cornea posted for refractive surgery. So we are also building software which can help tell us the actual orientation. You can see how disoriented these fibers are in the keratoconich eyes and in a suspicious topography also. So this will also be there once we commercialize it. And the day is not far because already the process of commercialization has started, and the future in next few years is going to be a combination of corneal tomography, epithelial mapping, and a polarization sensitive OCT, which is going to be into your clinics, along with retinal and glaucoma imaging in one device. Thank you.
Thank you, Pooja. It was a fantastic, very innovative talk. And as you have correctly said, now future is going to be a combination of all these techs to select our best patients. Thank you again. Thank you. So now over to Dr. Chitra Ramamurthy ma'am, who is going to speak to us about another tech in which we can actually understand how we can select our patients for the best candidate and also to choose the best procedure for our patient. And that technology is the corneal biomechanics. Over to you, Dr. Chitra ma'am. Thank you. We all know that Dr. Chitra ma'am has been the former ARC chairperson. She has done humongous work during that time as well. And she is the medical director of the Eye Foundations. And she is one of the pioneers of refractive surgery in the country, along with Dr. D. Ramamurthy sir, has huge experience. Thank you.
Yeah. Very good morning to one and all of you, and thanks, Vardhaman, for including me in your session. So my due is to talk on corneal biomechanics, and in spite of the fact that we have been doing refractive surgery for nearly 3 decades, in spite of the fact that there's so much of explosion of information, we are still not there when it comes to corneal biomechanics. But certain factuals are very, very clear in our minds, that the sclera is the strongest, then comes the Bowman's, then comes the peripheral third, then the central third, the peripheral posterior third, the central posterior, and last comes the descent. And this has been further corroborated by the electron microscopic study and the Brillion microscopic study to whatever extent possible. What we need to understand is that there is a regional variability in the cornea, and the stroma actually constitutes 90% of the thickness of the cornea, and the anterior stroma is actually the toughest with a highly interwoven lamellae, and it is 50% stiffer than the mid and the posterior stroma, which has to be kept in mind. And this actually gives it the resistance to swelling and preservation of the curvature. Whereas the posterior stroma runs limbus to limbus, is more loosely packed, but it does not mean it does not contribute biomechanically. It does resist deformation by the recti muscles, the eyelid blinking, and then comes a peripheral circumferential arrangement of fibers which allows absorbing small changes in the intraocular pressure. There are further variables in the biomechanics like the collagen crimp, which is the ability to resist deformation, which is again variable in the cornea. In other words, there is a non-linear viscoelastic behavior of the cornea. We also have to remember that there are hydration issues here, which also have a play in biomechanics, and the age-related stiffness and the natural claw sinking. So, when you are correcting a range of refractive error, for the similar part, for a 6.5 millimeter optic zone, the smile lenticule or the removal is more for the same as compared to a LASIK ablation. But then, the smile lenticule, as we all basically understand, is being removed from the deeper stroma, so which means probably that even if the smile needs more tissue removal for a particular refractive error, it leaves the cornea still stronger because anterior stroma is taken care of. Again, it does not have the vertical cuts, no disruption in the Bowman's membrane or the anterior stroma. And if you look at the smile lenticule, the peripheral cornea is actually untouched, whereas in the femtoLASIK, it goes inroads into the peripheral cornea, which contributes significantly to the biomechanics of the cornea. Again, this is something all of us know, that in PRK, below the area of ablation is the corneal biomechanical strength. In LASIK, below the flap and ablation. In SMILE, we wonder whether the cap does contribute to a little bit to the strength. The important thing to understand is it's the vertical cuts on the cornea which have greater impact than the horizontal cut, and deeper the flap, that also impacts. So for a deeper flap, the loss of hysteresis is more. If you've just done a side cut and not lifted the flap, then also the loss of hysteresis is more. And to that extent, the delamination cut of SMILE is less hazardous. Again, another study says that for 100 micron of ablation, for a similar Pacquiao 550, SMILE seems to fare better compared to PRK and SMILE. But then, there is to be understood that we are still limited in understanding the biomechanics of the cornea, how sophisticated and how appropriate these tools are in picking it up. So probably if you knew better about the biomechanics, we will know exactly what is the amount of lenticule to be removed in SMILE, what should be the incision, what should be the flap cut, what should be the angulation, everything would be there. So then, with the little understanding of biomechanics, came the concept of doing SMILE extra, wherein you leave riboflavin in the pocket and then do exposure to ultraviolet with low fluence on the cornea. Then, of course, there were different studies, but then it was only ORA which was telling that the biomechanics was better. Of course, the protocols were very variable, so there was some need of standardization to understand where we are. Although we do know that cross-linking is contributing to biomechanics, although we may not have the exact tools. So why are we talking about so much of biomechanics is because there is a challenge. You might be treating a 30-year-old, which we did in our practice, who had standard evaluation and developed ectasia. And there was a young guy who was very keen on LASIK, had minuscule pre-existent risk factors, but did well. Which means that the specificity and the sensitivity of our tests are still not there where it should be to exactly measure the biomechanics of the cornea. So in fact, if we can understand that biomechanical status of the cornea, we would not take up these eyes. So how are the ways which we can explore the biomechanics if you could find it out right in the stage where there is just a focal thinning, or at a biomechanical level, or at the tomographic level, or at the topographic, or do we wait for the slit lamp level? So biomechanically, today we have the oculizer and the corvis. Tomography, you look at the posterior flow. Topography, you look, there's significant damage has already occurred, and slit lamp is the last step. Although there are innumerable in vitro studies, but in vivo, these are the only machines which are technology which is there, which tries to superficially assess biomechanics. Ocular analyzer, however, the sensitivity and specificity for KC has been quite weak. Corvis, of course, measures the corneal deformation in 16 dynamic parameters, and it tells you which cornea is better or stronger. It differentiates a normal from a weaker cornea. And today we have these new indices, which is actually a step forward, and these have been undergone a linear regression analysis, and that's how a corneal biomechanic index came in. These I'm not explaining because of the paucity of time of each of these, but then the TBI seemed to be even more superior, wherein artificial intelligence combined the corneal biomechanical index and the pentagram tomographic values, and it was this Vinciguerra report came forward, which actually put across eyes which were safe, which were suspect, and which were at risk. And it was seen that the TBI specificity was actually more than 98% compared to bad or a CBI. So basically, we all know there's a genetic predisposition which gets aggravated by environmental factors like eye rubbing, atopy, and others. So look at this case. Now, the topography is totally normal. The bad display is totally normal, but the TBI is bad. So then we looked at the left eye and it showed frank keratoconus. Oh, so the TBI is important. The second case, the topo is normal, the bad display is normal, but the TBI is also normal and the other eye had keratoconus. So then we are not there. So even the TBI is normal, the other eye could have keratoconus. This is the third example, the last, wherein the topography was normal. And of course, there was small, the staging was fine. But in the TBI, the version 1 says that it is in orange. It is not too ideal. And the CBI is also in the red and the bad is in the yellow. So the version 1 says it's suspicious, but it was a small refractive error. So in the version 2, it came across that the TBI was not actually where it should be. So then, if this patient had undergone the version 2, he would not have been taken for a SMILE procedure. So probably the issue is we need to understand more and more, and we are not there. Like, although Pooja did talk about a lot of imaging devices, Brilliant optical microscopy results are also weak. Probably polarization sensitive OCT is there. There are innumerable studies which actually tell us that end of 6 months, all these 3 procedures are okay. Maybe initially SMILE is better, but largely there are many more studies says that the PRK is the best, then comes SMILE, then comes LASIK. There are very few reports of ectasia after SMILE, but then what did we understand with my 8-hour monologue on biomechanics is that there is an awareness, there are tools which are evolving, but till we are there, the selection criteria, be it for SMILE or PRK, has to be as stringent as LASIK, which anyway has vertical cuts, and we know that it is leaving the cornea weaker. Until that day, if it evolves, probably if we understand better about biomechanics, we would choose our cataract patients better, we would choose our corneal graft patients better, and we would be all the more evolved in refractive surgery. Thank you.
Thank you very much, ma'am. It was a very nice comprehensive overview of the biomechanics. As you have rightly said, currently, till the time we have more evidence, definitely the selection criteria for both SMILE and LASIK has to be the same. Thank you again. Thank you. So as we discussed, we are finding the right patient, and to find the right candidate, we require now armamentarium tools, because all these different tools come into play in those minute fashions when you're looking at borderline corneas. And one such amazing tool is to look at the role of epithelial map with the help of OCT in our patients of refractive surgery. And to take us through this, we have Dr. Kumar Doctor, who has been at the forefront of refractive surgery. He is the past former member of the scientific committee of AIOS, the past president of IRSI, and he is going to take us through the epithelial mapping. Over to you, Dr. Kumar.
Good morning, everybody, and thank you, Vardhaman. I'm very happy with this hall audiovisual guys because they allowed me to use my laptop. I was struggling in hall 2, and it was a conversion to PowerPoint to something, and I was sweating from morning. But this is a good hall. So this is about epithelial mapping and refractive surgery. We have gone through a lot of things. Previously, we had ultrasound. Then we have Artemis coming through. Okay, why is this like this? Let me see.
Pradhan is here.
So again, that was another system where we used to look at the epithelial map, but now modalities have developed a lot. So we have to look at OCT-based and the anterior epithelial mapping. Luckily, we have Pooja in the hall who does a lot of epithelial mapping for everything and will correlate everything with everything. So that's a good news. But I'm just going to tell you my little experience because I've started LASIK in 1999. We never looked at the epithelium. And suddenly epithelium has become very important, and we'll tell you why. So this is just a modality that is nowadays available. Now look at challenges faced in refractive surgery. One is ectatic corneas, which we know that we can't do much about except all the other treatments like TREC or Intax or whatever you want to do, or a subclinical KC. So now we'll look at how epithelial mapping is going to change our looking at different things. So we have OCT-based devices which have a wavelength of 830, and it covers the central 6 millimeters, and it also looks at anterior-posterior curvature and the power. And of course, it's repeatable and it's reliable. So it's important to screen now every refractive patient for epithelial thickness, and I'll tell you why. The corneal epithelium can mask irregularities of the cornea, and it's important to analyze whether it's pre-ectatic cornea while planning refractive surgery. So in the diagnostic checklist now, it's very important to include, of course, topography has to be done, ocular wavefront analysis has to be done, dilated acceptance, all those things have to be done. We are looking at the stroma most of the times, but we are forgetting the epithelium, because the epithelium many times masks irregularities or causes irregularities, and that can cause a complete change in your result of refractive outcome. So this is a simple case, very straightforward. You can see a good epithelial thickness, 56, 55, all over uniform, and everything is fine. So these patients are good. So role of epithelial thickness mapping is very, very important in post-refractive surgery. Sometimes a patient comes back after 5 years, 6 years, and you feel that the number has regressed. So previously the patient was -6, they come back with a -2. You may look at the cataract, but there is no cataract, then you have to look at the epithelium. Especially if the patient has undergone hyperopic LASIK, where we are not ablating the center, we are ablating the periphery, there may be an apical syndrome. The topography, the corneal thickness has to be looked at when we are trying to do a retreatment. And of course, direct measurements of the epithelium is nowadays possible with all the technology that we have. So here we are just giving an example of the OCT thickness of the epithelium, which is all around, you can see is 59, inferior 64, which is seen on the OCT, and the anterior, which is also OCT based, where you can get almost the same reading of central 2 millimeter and 5 to 6 millimeter and 6 to 7 millimeter. So you can compare the two technologies which are there today. Now let's look at case number 1. So you can see there is an inferior steepening. I did get a bad D, and the patient wants to have LASIK. So then what did we do? We looked at the epithelium, and you can see that the epithelium is even all around, and we ruled out any subclinical ectasia. So remember that if the patient has anything like a keratoconus, there'll be an epithelial thinning in the area of the area of the keratoconus. Now let's look at case 2. Okay, here this is an abnormal looking superior steepening, again a bad D, and the patient wants refractive surgery. So a pentacam may create a doubt, and your 4 map may create a doubt, but again we looked at the epithelium, and the epithelium was even all around, and the patient was fine, and the patient underwent surgery, and there was no other issue. Now let's look at case 3. Now again, no red flags. Pachymetry is excellent, 546. But when you look at the posterior surface, you see a central red. So this actually, I used to panic when I used to see this posterior float, a red thing looking at you. Everything else is normal. You can see the Berlin ambrosio is going a little downwards. But one thing I learned from Rohit, and he told me, look at the white to white. So the white to white in this case was 10.5, and that's giving that red, which is in the center. So this one thing, don't get misled by just looking at the map and thinking that this could be a early form flukes, but actually it's not. It's just that the white to white is small, and this is what happens in pentacam. And when we did epithelial mapping for this patient, it is absolutely even. So there's really nothing to worry, and this patient can go ahead and have whatever type of laser procedure you want to do. So this is one thing as far as the epithelium is, again, analyzing backwards, it helps you to analyze again. Now let's look at case 4. So here you can look at the anterior float. There is a suspicion of a steepening, okay? And the patient's vision is 6/9. So now the confusion is, what will you do? Okay, I'm not specifically saying, just presume that all the refractive errors are in the range of the pachymetry that is necessary for any refractive procedure for these patients. And that's the reason why we are not mentioning any refractive error here, because we are looking at the pachymetry, but remember that all of them are in the normal range. So again, we looked at the epithelial map, and you'll be surprised that the thickening is not in the area of the steepening. So again, this is a retrospective analysis that we realize that this is, again, a hypertrophy epithelium, not in the area of the steepening, and the vision is 6/9. So patient had surface irregularities, and that's the reason why the patient was given cyclomune, given lubricants, and then observed. So such patients, I may not go directly for a refractive surgery, just wait and watch, and see when the surface improves, recheck the epithelium, and then take a call what has to be done. Case number 5, 25-year-old. Now this is interesting, and I would like all the panelists, including Pooja, to look at it. That 25-year-old wanted refractive surgery, 3.5, 1.5. Everything else is normal. And this is the pre-op pachymetry and the map, 4 map, which is looking very good. And this is the other eye. So I did lenticule surgery for this, and the patient was extremely happy with one eye and unhappy with one eye. Okay? Unfortunately, I don't have the pentacam report, but I'll show you something very interesting. So this is the pre-op epithelium, okay? And this is the pre-op epithelium of the other eye. Don't forget, I'm doing lenticule surgery, okay? Now you'll say, why the hell are you bothered about the epithelium? But you'll be surprised what I see post-op and why the patient is unhappy. So this is again pre-op, everything looking good. 49, 47 may not be normal if you consider 55 as normal. And now let's look at post-op, okay? And look at this. So this is, of course, post-op. So this is what has happened post-op in the left eye. So I don't know whether any of you lenticule surgeons have seen anything on the epithelium after lenticule surgery, an unhappy patient. So there is some hypertrophy happening at the epithelial level. When I've done a lenticule surgery, I'll finish in a second. So I don't know, I would like comments from all of you whether you have done this, seen this, noted this, because I just realized why the patient was unhappy in one eye. And you see the surface, everything is good. I mean, the area of the stroma, very good, very smooth, no striae. We dilated, we checked on retroillumination, smooth, everything is fine. But patient is unhappy with one eye. So this is just a thought and an observation which you can take up. So in conclusion, now, I think over the number of years, epithelium is very, very important. I think it should be a routine like doing a topography. You can customize your surgery according to the flap thickness. Of course, when you have to do a retreatment, please look at the epithelium because it will be hypertrophied sometimes, which gives a wrong result. And it can unmask stromal irregularities, important in ectasia prediction, and improve surface laser treatment. So for surface treatments, of course, epithelium thickness is very, very important. A lot of references, majority from Pooja, so can't help that. Thank you very much. Thank you.
Dr. Kumar, I'll just take one question till Dr. Pramod gets his presentation fixed. If a person has increased corneal epithelial thickness and you're going to do an enhancement for this patient.
Say that again, least.
Patient's epithelial thickness is more than normal and you're going to do, he has a residual refractive error and you're going to do enhancement. Would you prefer to do a PRK or you prefer to do a flap?
So, firstly, I would like to know the pre-op epithelial thickness. And if the epithelial thickness is really much more, it's better to just scrape off the epithelium, don't do anything. Let it regrow, remodel, and then see what happens. I will not do anything.
Rajesh, would you think differently?
Rajesh, you have to agree with me.
I think it depends on what degree of regression she's talking about. If it is only in the range of 0.75 to 1 diopter, then we know that even a 10 to 15 micron increase in epithelial thickness can produce this. Then I would agree with what he said, that we will debride that hypertrophic epithelium, let the epithelium become normal, and then look at the refraction again. Because if you were to go back and do a treatment for that, then you might create hyperopic shift for the patient later on. At the same thing, if you're treating trans-PRK, for very low myopias, always pay attention to epithelial thickness map. I had done a trans-PRK for a 0.75 minus, and my patient came back with the same refractive error, minus.
Same refractive error.
And that was because his epithelial thickness was 65.
Yeah. No, what so, my thought was, it wasn't such a small residual. The patient had some minus 1.5 or something. Would I, and the patient, it's still early on, like hardly a year and a half since the primary procedure. So in those situations, I would lift the flap and treat, then play around with the epithelium is what I would do, and I wonder whether you concur with that.
No, if that fellow eye also has a similar thickness in epithelium, so that's the normal thickness of the epithelium for the patient, then it makes more sense to do a flap-based procedure. Yeah. But if the other eye epithelium is like 50, but this eye you got hypertrophy, then I would agree that we will
but then if you do again a PRK or anything, the epithelium is going to not heal less. The same issue is going to happen. So why not treat it?
Even to do a flap-based procedure, I would like to normalize the and then know how much to treat.
You can repeat measurements and
The
check.
SMILE procedure, that the lenticule procedure where you had irregular epithelium, one way to get over it is to do temporary punctal occlusion for the patient.
Dry eyes, yeah.
Because the dryness produces this
Yes,
kind of irregularity of the
exactly. Yes.
epithelium.
We are
So if you
treating-
just plug the
Yes.
lower punctum with chromic catgut or a temporary plug, you will see improvement. Otherwise, you can even put a bandage contact lens for the patient and see, because that will also allow the epithelium to normalize, and then you can see whether that
Yeah.
results in resolvement
Yes.
of the symptoms.
Right answers, yeah.
Thank you. Thank you so much, Dr. Kumar. Now, I think we would like to go to the next talk, which is something very, very crucial. And I think the retinal examination, especially for the peripheral degeneration, is of paramount importance in refractive surgery. And to take us through what are the current evidence of peripheral retinal degenerations, when to treat, when not, when to observe, which ones to treat, which ones to observe in the setting of refractive surgery. We have one of the senior most retina specialists that we have in our country, one of my teachers, the head of the Department of Retina subspecialty at the prestigious Shankar Netralaya, Dr. Pramod Bhende, sir. So over to you, sir, and thank you for accepting our invite.
you.
Thank you.
Thank you very much, Dr. Vardhaman and AIOS for having me here. I think it's nice to have a last talk because I can see a few audience now. So, okay, coming back to peripheral degeneration and refractive surgery. So basically, what I look at it, probably I put in a different heads. What is the risk of detachment in myopia and why does it occur? Basically, why? Because most of the procedures are being done for myopia and very few for other refractive surgeries. What is the procedure that is planned? Does the risk change with the procedure what you chose? Which eyes would I treat? And what is the safe interval between laser and the procedure? That's extremely important for all of us. And what are the problems as a VR surgeon I would face in an eye having a detachment post-refractive surgery? We'll go one by one. So overall incidence of detachment in a myopic eyes, you will see somewhere 0.015 to 0.017, look at various literature. But patient with a higher myopia having a much higher incidence of retinal detachment. And why is it so? Probably because you get an early vitreous liquefaction leading to early PVD in these high myop eyes. And also with increasing axial length, stretching of the eye wall, there is a higher incidence of peripheral retinal thinning and lattice degenerations. So there are different refractive techniques, what you have already discussed. A lot of things are there, you people know better than me. So, but when you look at, again, literature, there's a little bit controversies, but reported incidences in RD following refractive surgery is relatively higher. That's 0.04 to 0.33 as compared to 0.015. Now, interval, when you look at between procedure, refractive procedure and rheumatologist detachment, variable anything between 2 months to 10 years. And even cases with the bilateral retinal detachments post-LASIK have also been reported. A little bit biomechanical changes, what you see, I'm not going to go in every detail here. LASIK causes a sudden increase in intraocular pressure because of suction ring, which followed by a sudden decompression. Excimer laser sends a shock wave inside the eye. Film to LASIK, though you have lesser suction pressure, but probably it takes much longer time, so probably effect is same. And SMILE docking is done, but generally there are not much significant intraocular pressure changes in the eye. And refractive lens changes obviously is intraocular surgery risk, all of us know about it. And obviously most of this procedure, what will lead to eventually premature PVD and leading to, which is a precursor for retinal tears and ultimately leading to retinal detachments. So when you look at the second question now is you're having so many procedures, does risk varies? So when you look at PRK, LASIK or SMILE, probably risk is more or less same as eyes without the procedures because most of these eyes are high myop. But probably it is relatively less with SMILE compared to other three procedures. Phakic, IOL and ICL, again, probably risk is more or less same in myopic eyes, but again, intraocular surgery risk is almost double to develop detachment when you look at a literature support. So recommendation for here as a VR surgeon, look at the type of refractive surgery being performed should not be a criteria to decide the prophylactic treatment for peripheral retinal degenerations. But retinal examination of myopic eyes undergoing refractive surgery, both before and after procedure, should be performed in every case. and prophylactic treatment of retinal degenerations, which can predispose to retinal tears or detachment, is advisable. Of course, there are few controversies as there. Detachment has been reported even after prophylactic treatment or in a patient with no peripheral lesions at all. So that's always a separate group is there. So what are these lesions you would like to treat? What are something called as, those are precursors of regumatogenous retinal detachment. The list is here. I'm not going to go again in detail, leave it for VR surgeons to handle. So basically what you would like to do is, which eyes would I treat is basically all eyes with high risk. What do we mean by high risk is high myopia, particularly having a family history of myopia or other retinal detachment or retinal lesions, or patient already having a retinal detachment in one eye and going for treatment for other eye. All symptomatic treatments, congenital disorders, typically what you see in a Stickler syndrome. And of course, eyes with extensive area, generally as a VR surgeon, we would like to observe, but that's a little bit gray zone. If you are doing any refractive procedure or intraocular procedure, we prefer to treat these eyes. So what is a safe interval? The next question is, what we look at literature again, and evidence suggests that to retinal adhesions to have a little bit reasonably firm adhesion takes 2 to 3 weeks, though firm choroidal scar is firm up to 6 weeks. So anything more than probably 3 weeks, probably reasonably safe period to go ahead with refractive surgery. Of course, again, PVD evolution takes almost 6 weeks. And so if you can wait for 6 weeks, probably that is better, because anything, if something has to go wrong in between, you know that and you can treat it before taking the patient for your refractive surgery. But degenerative myopia, you do not know. It's absolutely unpredictable. And obviously, if there is pre-existing PVD, having other lesions, we do not have enough evidence which way it will go. This is just to show what you really actually look for is something like when you do a laser treatment, these are the pigmented scar, and that's the probably ideal way to wait for these scars when you take the patient for refractive surgery. Caution, as I said, we already told prophylactic barrage laser should be recommended to all retinal lesions before refractive surgery. But what we know is 5 to 14% of patients with the initial retinal breaks will develop additional breaks during long-term follow-up, even when a patient has had prior adequate treatment. So that adds on to all this patient needs additional examinations and extremely important pre-procedure counseling, particularly that informing them that things can still go wrong and they need a long-term follow-up, particularly if they are having a degenerative myopia. Now, just on a lighter note, but yes, these are practical issues when, as a VR surgeon, I deal with him. Pre-operatively, patient expectations are basically because he has gone to refractive surgery. And when you plan VR procedure, and if I put something scleral buccal or something like that, or refractive things are going to change, so we need to counsel them, or shall we not put, so shall I use or choose another procedure in these eyes? Intraoperatively, post-LASIK flap dislodgement, distortion, in a post-RK patient, ICL cause a lot of distortion. All these issues can be visualization issue during vitrectomies. And post-operatively, again, induced myopia and astigmatism can be issue and headache for the refractive as well as VR person. Basically, that's a common question. And also, post-vitrectomy, they can have a cataract, astigmatism, and glaucoma. And obviously, another big question is, once we induce the astigmatism or refraction, myopia post-vitrectomy, is post-RD surgery refractive procedure is advised or not? Just, I think I leave that question open. I acknowledge to Dr. Muna and Dr. Sampurna, and thank you very much for patient hearing.
Thank you, Dr. Binde. That was a wonderful talk, and we did know some of these, but it just got strengthened that this is how it has to be. Thank you. Yes? Snail track?
Yeah, snail track probably precursor of what you would say, sometimes it causes problem, or most of the time it's like early stage, probably over a period, it may remain as it is, but generally they are fairly safe.
Fairly safe. Okay.
So as we discussed...
6 weeks becomes far too much to wait. You are sure to lose that patient.
Which one?
So, the laser barrage.
Yeah.
So, 3 weeks is also fair enough, right?
3 weeks is fair enough, I think.
Yeah.
And that is what standard generally we follow.
Generally
3 weeks should be more than enough, actually.
So 3 weeks, as you said, is enough for the laser refractive surgery. But what about like intraocular procedures such as phakic lenses, ICLs? Is 3 weeks enough, or you would like to wait more?
Any intraocular surgery, probably I would say what we know, inflammatory cascade, as we know anatomy, probably 6 to 8 weeks the time we need a scar strengthening. I would people wait for that. But see, but taking for a surgery, because laser is done and after that you are taking for surgery, that does not change.
No.
But any additional procedure you want to do after doing your ICL or phakic IOL, then probably other procedure you would like to wait. But after laser you want to go ahead with 3 weeks, that's fine.
Okay,
Yeah,
for
yeah.
the phakic lenses also.
Yeah, yeah.
Yes.
Are these non-mydriatic wide field imaging of the retina is a good alternative to a dilated fundus exam, or all patients should have,
We still,
like the Optos, you have Optos?
yeah, we have
as well.
Optos, but still sometimes few areas you're likely to miss, and particularly if pupil is not well dilated, still you're likely to miss periphery, and obviously it will be better like a indirect ophthalmoscopy with particularly scleral depression.
After all that was said by Pooja and me about corneal biomechanics, some of you who have Corvus, if the TBI is in the red or in the yellow, would you consider these patients, Pooja, you can be involved, would you suggest these patients for PRK or would you stick to SMILE?
Ma'am, based on the refractive error, we'll choose either between trans PRK or a SMILE, but with an extra procedure, which is a flash cross-linking.
Yeah.
So always one of it.
But PRK, we do understand that there is some amount of inflammation which happens in the healing process. In fact, the people would say that you don't have to cross-link these eyes at all. So why not in those suspicious cases opt for a PRK? If you can counsel the patient that there's going to be initial discomfort, then do the SMILE extra. Your thoughts?
Agree with you.
Yes.
Yes.
You can ask. Yeah. Any other questions from the audience? This is the best time to ask and we could all clarify together.
See, my question is, anyone who can afford an excimer or a femto can afford a biomechanics tool.
Yeah.
It is yet not caught on and yet not hot. So now the question here to Pooja is, how many of her patients, which they have analyzed everything, okay, and it's passed on biomechanics and still developed an ectasia?
Actually, before Pooja adds, Pooja, you can tell, none of our extra patients have developed ectasia. Not that we took on frank ectasia cases, these were suspect cases. So neither was it, there was a haze, nor was it impacting refractive error, and we've been doing extra for more than 10 years now. So I do not see why we should shun it, because we know that cross-linking is definitely contributing this to strength, and half fluence seems to make sense.
So I would say that biomechanics for us helps a lot, because for all our patients we do biomechanics, and based on topography and biomechanics we choose which would be the ideal practice. Whenever we have gone for SMILE extra or a trans PRK looking at biomechanics, we have never gone wrong. Where we have all probably gone wrong is, like Rajesh sir said very nicely, is qualitative analysis of topography. Very long back, you know, your corneal thickness used to be 580s with skewing, but biomechanics used to be very good. We have done LASIK for those cases, and that's when we have developed ectasias. But with biomechanics help, choosing a SMILE extra or PRK, we have never gone wrong. So I think biomechanics is there to stay. I just believe that probably we have to use it in the right way. So. Off lately, since past 6 months, our extra patients have become almost 25% in the practice. I'll tell you why, because last 10 years, we've not had any case, ma'am said, of SMILE extra developing an ectasia. We have had a case of SMILE or LASIK developing ectasia, but not any case of extra. So extra is always a good thing, and we always tell patients, see, it's not that you need it, but we are doing it as a precautionary procedure, so don't get worried about it. So we've never gone wrong with extra, at least at this point of time.
At least the regression part of it has also stabilized.
Regressions are very less with SMILE.
But SMILE extra, there is one query which maybe Rajesh would bring up. We are eating it's like a trans-epithelial PRK. So then that way you can question it. So I strongly believe that if cross-linking has a role, it's PRK extra more than SMILE extra.
One thing that I would like to highlight is that if you look at the axial maps on a pentacam, they're not as good as what you see in a Placido-based topographer.
Yes.
So if you want to look at a qualitative aspect of a topography map, you have to fall back. Like TMS is great I've started with TMS1, gone up to TMS4, and we can pick up many more cases which are abnormal than all these various indices that you use. In fact, in some of the presentations, what you show cases as normal topography, showing abnormal other parameters. In the qualitative map, that's abnormal. Even when I look at your map, I can already see the asymmetric bow tie and slight skewing. But so that's why you cannot give away topography as saying that, only tomography, unless your tomography has a good Placido-based imaging system and you don't have a qualitative good imaging of the axial map. I think that is something that people are forgetting, that you really need to look at the qualitative aspect of the topography as well. And epithelial mapping is again something that masks. So very in early cases, those are the two things that I would lay very much importance on. I want to see the good qualitative map, axial map, and I want to look at a good epithelial map. Because in epithelial map, the slight thinning of the epithelium at the apex and a surrounding thickening, that is something that will pick up an abnormality much earlier than any of the biomechanical indices.
Absolutely. So I think the take home is basically for anyone who would like to have refractive surgical practice, the essential tools that you should have is a nice Placido with tomography, and if you have access to OCT nowadays, everybody has OCTs and segment practice. If you can add the tool of epithelial mapping, that should resolve more than 99% of your issues.
Can I make a brief comment here?
Yes, brief.
So
It's
very brief.
9:40,
I would be very brief. So one thing is we have to understand post-LASIK ectasia is multifactorial. Incidence is very low.
less.
So whatever we say we have done this thing is work or something, that's related to incidence is very low. Also, it's not always the pre-op factor. We know that from Demel-Gatinel study that the post-op, when patients have indirect eye rubbing, direct eye rubbing, they are the main culprit. So irrespective whatever we do, if we do not take care of them, we still can end up ectasia.
Yes.
So it's not just one particular thing.
Yes.
Point very
Even
well
pregnancy,
taken,
everything
Dr.
can have
Himanshu.
an...
I would like to just ask all the speakers to please come forward for a group photograph, and then we can hand over to the next session. Thank you.